Hello, good evening. Today it's World Pharmacist Day, and we just bring you a simple video as a bonus video because today is our day, Pharmacist Day. So I would start by saying Happy Pharmacist Day. It's an amazing day indeed, and I'm glad to be part of this profession. And one thing that I love is to see people getting the best and be part of the team that is changing lives by providing best care possible for every patient. That's what we are here for. I'm glad to be connected to a great team that I work with, people that inspire me every day to be a better person, and it's really an honor, and I thank God for that. Okay, so I have a simple video here tonight, and I just want to actually talk about some drugs that I use in first-line TB. So you can leave a comment and we'll respond to this later. Okay, so basically it's very interesting to understand tuberculosis. I won't gonna be talking about detail here about TB itself. Yes, just a short video I'm making here. I'm not gonna just talk about all other things or basically. So TB is a very common disease right now, tuberculosis. Okay, it's a multi-systemic disease, of course, that affects multiple systems in the body, and this disease, of course, that means it can affect the lungs, can affect the bones, the kidneys, the brain. So basically it's caused by the organism known as the Mycobacterium tuberculosis, MTB, and there are different species under this, of course, that can cause that is Africanus, bovis, and of course the hominis, which of course is the one that causes disease in human beings, the most common one. Okay, so this organism, Bacilli TB, of course itself, it's actually it's a acid-fast bacilli, means it does not stand really much for gram-negative or gram-positive, but it's a bit of somehow also gram-positive on the side of gram-positive, and it has got different multiple layers. We've got the macrocytes. The layer, of course, itself of this organism, it's got really multiple layer. The first part, of course, you see some mycocytes on surface, and then we've got the mycotic acids, then followed by the this layer known as what we call the arabinogalactam layer. The arabinogalactam layer, then of course inner there we have also another layer known as what we call the peptidoglycan layer, which it has. From the peptidoglycan layer, you've got also the inner layer, of course, which is the cell membrane, of course, itself. So you see this organism, of course, is made up of a lot of lipids on the surface. Okay, a lot of lipids on the surface, and that's why it does not stain well for gram-negative or positive, but rather it's acid-fast bacilli stain. It's good for identifying this organism. Now, I won't really talk much about TB. Of course, you can get TB when somebody, of course, who is infected with this disease coughs on the aerosols, of course, you inhale. Of course, exposure also matters, and that's how you can have this. Of course, the lungs being the primary site for this is a common site for this infection because this is an aerobic organism, meaning that it loves oxygen. So in tissues rich in oxygen, this organism, of course, really thrive and may cause invasive diseases, and that's why its lungs are much primary site. Of course, you can have TBM, which is TB meningitis in the brain. You could have all those manifestations. A spine, because those are the areas where you have got more division of cells occurring and making of new cells, where there's much preparation and there's much rich in oxygen. That's where these things are happening. Okay, so basically, on the but of course, this affects recent studies, of course, the report saying that about 2 billion people have got TB, as latent TB, where of course people, of course, are immunocompetent people, but they have the bacilli organism inside their body, but they are not manifesting disease itself as TB, or rather symptoms are not, because they have got enough cells which are able to contain the Mycobacterium tuberculosis, of course, of the organism. So not able to manifest this. Primary TB is when a patient that is actually, those are non-sensitized patients and having the TB for the first time. But there's what we call secondary TB, whereby a patient who is already sensitized to the Mycobacterium tuberculosis either manifest the disease from reactivation or acquiring new organism, of course, from another person who is infected. Okay, so I'm talking about the first line drugs that we use in the TB, primary TB. For example, like, okay, so we have got the drugs that we use here. TB is treated in two phases. Basically, if it's first line susceptible TB, we treat it in two phases. The first phase we call it the induction phase, of course, which is of course or intensive phase, where we use 4 drugs in Zambia. Basically, we use these drugs. We use isoniazid. So isoniazid. We use also rifampicin or rifampin. That's can go. So Americans, they say rifampin. Get another one, of course, is pyrazinamide, and of course we've got the ethambutol here. So these are the drugs that are used currently first line, and they come, of course, in 4FDC. This I'm talking about adults. 4FDCs mean that these are called 4 drugs fixed dose combination. It comes as in 4 in 1. So it becomes easier. You know, a long time ago people used to take a lot of drugs. Imagine somebody's getting a lot of drugs for TB. So, but now, you know, science, with this development of technology, we are able to combine these drugs to make a 4 in 1, where a patient just takes 4 in 1, and it becomes easier for patient compliance, which is a good thing for that matter. So okay, so how first line drugs, basically as first line drugs for this, we use, as I said, the isoniazid, rifampicin, pyrazinamide, and ethambutol. These are the first line drugs that we use. So we use these drugs, of course, all of them for 2 months, and after that, of course, we discontinue pyrazinamide and ethambutol, continuing on the 2 drugs. We call them the 2FDCs, where, of course, isoniazid and rifampicin for 4 months, of course, if it's PTB, so making the total of 6 months if it's primary, of course, TB susceptible. But if it's other type of disseminated TB, where we would have TB-M, TB meningitis, or TB spine, that one, of course, we go for quite longer, like up to 1 year treatment in that aspect. So these first-line drugs, I want to talk about the first bit about their mechanism of action, and what are the things that you have to look up to. So the thing that, of course, these are drugs that are used, we give patients for quite a longer time. So management of the adverse effects is very important, because this, of course, determines whether the patient will comply or to treatment or not, or whether adhere to this regimen or not. Because so the first phase, of course, is intensive phase, where we aiming at having of course, sputum clearance, where we have negative taste from the sputum itself. So we use these drugs, of course, 4 of them. And in other countries where resistance is not an issue, they don't really worry about adding ethambutol. Use just the 3 drugs are able to actually work very well. The rule, of course, of TB treatment is basically to avoid monotherapy. So don't use a single drug. So isoniazid and rifampicin, these are these are core drugs. These are the very most effective drugs, and they're very actually good. They work very well. Like isoniazid, in the case of isoniazid, this drug works well, of course, intracellular, of course, because the TB organism, of course, Mycobacterium tuberculosis, is an intracellular organism which loves to thrive or multiply inside your macrophages, which are your cells that are found in your lungs and or other part of the body. But in this case, I'm talking about the lungs as the primary site, of course, most common. I'm not saying it's the only site for this disease. Okay, so I'll start with isoniazid. Isoniazid, basically, this drug is actually it's an analog. It's a prodrug, an analog of pyridoxine, and it's a prodrug which is get activated in your liver by the hepatic, of course, CAT-G enzyme. Of course, this activates this isoniazide. When this isoniazide, of course, get activated, how does it work? It works basically by stopping, by simply inhibiting the synthesis or the production of the mycolic acid. Mycolic acid is part of the cell wall of this Mycobacterium tuberculosis. It's one which makes its, of course, cell wall structure. And then isoniazide works by stopping the production of the cell wall. A cell wall is more like a skin that you have as a covering. Imagine we give some drugs that stops you from, stops your production of skin. That means you easily die, of course. The skin protects us from a number of things. The same way this drug isoniazide works by stopping the production of the cell wall of this bacterium, of course, itself. And it does this by simply stopping two special enzymes that do this work. There are special enzymes that are doing this work. That's these enzymes that are able to do the work of producing, or rather making the mycolic acid. And this enzyme, of course, one of them is inoacyl carrier protein reductase, and another enzyme is called beta-ketoacyl ACP synthase. These are the two enzymes that are involved in the production of the mycolic acid. Isoniazide works by stopping those enzymes. So this is how it works. This is the mechanism of action of isoniazide. Isoniazide. Now let me talk about the adverse effects that you have to worry, the things that you have to be concerned with when somebody is on these drugs. I won't talk about many side effects that you read. I won't talk about all of them. But in isoniazide treatment, of course, you have to also worry of that people may have what we call peripheral neuropathy. Okay, isoniazide can cause peripheral neuropathy, bring about neuropathic pain, where people, of course, initially present with this positive symptoms of peripheral neuropathy, where some tingling sensation tingling or burning sensation in the peripheral tissues, let's say in the legs. That is called positive signs of peripheral neuropathy. And of course, you have also later on, if it worsens, it goes to the negative symptoms like numbness of the limbs. That is negative symptoms of neuropathic pain. So that is the adverse effects of isoniazide, and that's why we give these patients are taking isoniazide together with pyridoxine, which is B6. So this, of course, is used to prevent this adverse effect, which is peripheral neuropathy. And the people who are at risk of having this peripheral neuropathy are people who are HIV infection, of course, and those people, of course, also who actually are actually immuno. I would say the right word is the people that are malnutrition, where there is reduced nutrition. Of course, the patient himself, and diabetes, of course, also puts them at risk. Diabetes disease, of course, them also put them at risk. And people who take alcohol also at a higher risk of having peripheral neuropathy, because alcohol depletes almost all vitamin B's, of which are important in nerve synthesis as well as dopaminergic, of course, production. So another side effects of isoniazide that you have to be also looking out is hepatotoxicity, which is, of course, hepatotoxicity. It can cause also hepatic dysfunction. Is actually one of, maybe I should say, the second toxic drug among the three drugs that are known to be more toxic to the liver. So isoniazide also causes that. Another thing that you need to know about isoniazide, that it also can cause, isoniazide can cause psychosis, because B6 is important, of course, also in what we call GABAergic synthesis as well. So isoniazide causes these, depletes this B6 in the body by simply inhibiting also another enzyme that, of course, which is important in activation of vitamin B6 from the alcohol state, which is the inactive state, to the active form, which is the aldehyde state. And this enzyme is known as pyridoxal phosphokinase. Yeah, so that's why it brings about this psychosis as well as also peripheral neuropathy. Another one, of course, side effect, of course, is also may cause seizures, because they lower seizure threshold. So people may present with seizures with this drug. And of course, different type of skin reactions, rashes. People can have what we call maculopapular rashes and macules, especially darkened skin, and all that can be caused by isoniazide. Okay, going to the next drug is rifampicin. Rifampicin, basically, it's actually most well-tolerated drug, of course, and how it works, basically, that inhibits the DNA, of course, enzyme known as, this enzyme is known as the the DNA-dependent RNA polymerase. It polymerizes the RNA, so it makes the RNA from the DNA in the microbiome, of course, organism, and that's how rifampicin that blocks that enzyme. If we block the DNA machine and making of the DNA in your body, means that cells won't be being multiplying in the body. There will be no regeneration of skin, no growth, because we are blocking the DNA synthesis. That's why people when blocking the DNA by using different drugs, people may present with loss of hair, reduced cell count, which is pancytopenia in the body, because all those requires DNA is important in your growth. So rifampicin stops the growth of the organism by stopping the DNA synthesis. And of course, this drug, of course, is generally tolerable. And what you need to worry about rifampicin adverse effect is that you're concerned of what we call, it can cause discoloration of body fluids. So somebody who had a surgery, let's say, put on those that are using the contact lenses, this drug may stain the contact lenses. So sometimes people, like patient, will tell them, like, when you start taking these drugs and then you notice that you'll be having change in the urine color, orange to red, don't be afraid. It's not that you are bleeding, it's the drug, of course, may change the color of your urine. Of course, that's a common thing that you see with this drug rifampicin. But from that, of course, it's actually also cause hepatotoxicity as well, hepatotoxicity. It also rare causes hemolysis anemia. Rifampicin, of course, causes that, and it causes rash. A rash that it causes is called petechial rash. It's more like generalized erythematous rash that you see, of course, with this drug. Another concern with this drug, rifampicin, is about that it's a potent isoenzyme inducer. It induces almost all the majority of the isoenzyme that are found in the liver. These include cytochrome B4 isoenzyme 3F4, 2D6, 2C19, 2C9, which metabolizes a variety of drug. And cytochrome 3F4 basically metabolizes almost half of the drugs that are used in practical. So interaction with these most drugs, actually it affects with some of the drugs that we use in HIV. That's why we double some doses of some medication in our patient, because if they're on TB treatment plus the HIV drugs, so some drugs, of course, get to be reduced or rather metabolized to the extent that they become less or rather reduces the minimum inhibitory concentration, so thereby we double the dose in that cases, or that instances. The next one, of course, is pyrazinamide, which is PZ. Pyrazinamide, of course, this one also works by simply stopping the fatty acid synthesis as well, by stopping the synthesis enzyme. That, of course, also so without this stops in the this organism made up a lot of lipids layers, so fatty acids are needed for its structure, of course, mycotic acid. So PZ stops that fatty acid synthesis as well. And the adverse effects of this drug, the culprit one, of course, what about is hepatotoxicity. So pyrazinamide is the most hepatotoxic drug among the drug that we use, the first time drug, the 4FDCs. PZ is the most hepatotoxic drug. It's very toxic to the liver, and it can cause liver liver damage and liver, of course, failure if it's not actually interventions is not made. The other thing, of course, that this drug PZ as well, pyrazinamide, is known to cause hyperuricemia, and that's why it can precipitate gout. So new onset gout is rare, but of course it may precipitate, meaning that people who already have gout, and they could actually, it may actually cause acute gout, of course, which flares may be seen due to this drug. But new onset, whereby somebody who have never had gout before, then they've got gout due to PZ, this new onset is rare, of course, and it's not common to talk about as an issue here. Okay, the last one, of course, is the ethambutol. Ethambutol, of course, I say this is the least effective drug here, and it works well because it helps resistance, and in areas where resistance is a culprit. So we use it here in Zambia as well. It's a good drug. And the way it works, ethambutol, basically, that it works, this drug, the way it works is by simply inhibiting arabinogalactamase enzyme. Is an enzyme that, of course, it blocks, which is makes a layer that is important on the Mycobacterium tuberculosis, and this layer is known as arabinogalactam. And this layer basically is a very special layer because what it does, this layer, is that it makes special proteins that acts as anti-phagocytic properties, meaning that when the macrophage cells engulf this bacteria, they're supposed to kill it by simply fusing the phagosome, what it's been swallowed, together with the lysosomes. So lysosome, think of lysosome as a ball of acid, so that contains the digestive enzymes which are used to destroy everything that the cell swallows. So the protein that are produced by this layer known as arabinogalactam prevent the fusion of the phagosome and lysosome, thereby enabling the bacteria, of course TB itself, to multiply inside your cells. So that's why a drug we're giving Ethambutol is able to block that. So meaning that it makes this organism, of course, easy to kill and all that thing. So with rifampicin, of course, is able to wake intracellularly and also extracellularly bacilli, and able to clear out that. So Ethambutol adverse that you're worried about, of course, the one that you're worried with Ethambutol is what called optic neuritis. People may become blind. They're able to distinguish between the green colors. They're able to distinguish that. So we ask our patient that, are you losing sight? Has his sight changed, or started taking these drugs? Okay, it may also cause, it's also in renal aspect, also issue with the renal, worried people with renal. People with renal failure, of course, it puts them at high risk of having this side effect known as optic neuritis with this drug. Of course, it can also cause a bit of ear toxicity, and so this basically is the baseline drug that we use in combination as a fixed dose combination for the treatment of TB as first line. Now let me just, the doses that we use basically in terms of the doses wise, with isoniazid we dose it basically at 5 to 10 milligrams per kg body weight. We modify the weight of the patient. In children we use 10 milligrams per kg body weight, but in adults 25 milligrams per kg body weight. Rifampicin, of course, we dose at 10 to 15 milligrams per kg body weight. Pyrazinamide, of course, 30 to 40 milligrams per kg body weight. Ethambutol is 15 also to 20 milligrams per kg body weight. So you dose these medications, and this is how I had today for you this pharmacist day, World Pharmacist Day, and I just want to discuss with you a bit thing about TB and how you treat, and some drugs, of course, the way they work and their adverse effects, and now how you have to advise the patient how to take. So we tell the patient to take these drugs, of course, preferably 2 hours after meals, because isoniazid absorption is significantly affected by meals. So that's what I had, and enjoy the weekend. Stay blessed. So leave your comment in the section, and then we'll actually return to them. Thank you very much. God bless you.